Hi everyone, thank you for watching the ICOI webinar. My name is Homma, ICOI Ambassador in Japan. My topic will be the predictable digital treatment in aesthetic zone. What is the predictable treatment sequence in aesthetic zone? I know you guys have some idea or some technique, some sequence of the treatment plan for the aesthetic zone. In order to know what was predictable and evidence-based, you need to know the idea of the socket classification. My mentor, Nicholas Allen, and NYU group made a socket classification in 2007. The class 1 socket classification, class 1 means presence of buccal bone with a soft tissue. And the class 2, the lack of buccal bone with the soft tissue. And the class 3, combination type defects, means no bone and no soft tissue. When you take the tooth in the aesthetic zone, you're always going to have the soft tissue and the bone collapsion. But this class 1 case, which means you have bone and soft tissue on the buccal side, sometimes you can do the immediate implant placement or just wait with the soft socket preservation and wait 4 to 6 months, you get the implant placement, which is ideal socket type. How about class 2? When you take out the tooth, you don't have buccal bone on the buccal side, but you have soft tissue, which is commonly seen in the aesthetic zone. The patient had a fractured tooth or periodontal problem. You're going to have like a class 2 classification. And this time, you don't have buccal bone, so you cannot do the immediate implant placement. You wait a socket preservation with 4 to 6 months, and later you do the implant placement. Or just allow healing everything, and then let the soft tissue, the hard tissue collapse, and you do the implant placement with a GVL, sometimes with a connective tissue graft. That is treatment sequence for the class 2 socket classification. How about the class 3, which has no bone and no soft tissue? In this time, you cannot do no immediate implant placement and just wait, allow healing, and then you do a GBL, a GTL, and wait another 4 to 6 months, and then you do the implant and the later. That is a normal sequence. I know you guys have a lot of treatment plan and a lot of techniques, but this is like a normal sequence of the class 3. So we combined type 1 and type 2, type 3, which type 1 is ideal socket, and the type 2 and type 3 is going to be the compromised socket. You always seen the compromised socket in your case, and the slam dunk case is ideal socket. In my country, Japan, you won't see ideal socket. It's really rare because insurance, national insurance covered endodontic problem, and also you do the post and core, and then we can do the crown on the top. We covered by the national insurance. So the people wants to save the tooth. But when I study in NYU, even you do the root canal, your root canal costs like $800 for the one root, and the post and core is at $1,500 and $50 or something. And then you put the ceramic crown, which costs like $1,900 or something. So either you do the root canal, post and core crown, you take out the tooth, and you do the implant. That I was seen in when I was in New York City. So ideal socket is much higher in the United States. In Japan, it's really seen the ideal socket. I don't know your country, but my country, I always seen a compromised socket like type 2 and type 3. And also, when you do the immediate implant placement, you can do provisional or non-provisional. you can achieve. If you could achieve a good initial stability, you can put the provisional on the same day on the day of the surgery. But if you don't have much confidence with the um, initial stabilization on and or patient the blushing habit or something, you don't put you don't put provisional. And my mentor Dennis Tanner made the dual technique in 2010, which calls the you do the implant placement and then you compare with no provisional and no bone with the provisional, put the bone without the provisional, and put the bone with the provisional. He combined 4 types of immediate implant placement. My mentor Dennis Tanner made classification, which is dual zone technique in the aesthetic zone. He placed an implant and without the bone graft, no provisional, versus without the bone graft with the provisional, versus with the bone graft without the provisional, versus with the bone graft with the provisional. And he combined it together and they made a measurement. And when you put the implant and then between the implant with the back of bone, you don't put any bone graft, no bone graft, and no provisional, you're gonna have minus 0.5, 0.4 to 0.3 millimeter of gingival margin of the. My mentor Dennis Tanner and his group, they made a classification. They put the immediate implant in the aesthetic zone and between the buccal bone to the implant. That type A, you don't put the bone graft and you don't put the provisional. Type B, you put the provisional without the bone graft. Type C, you put the bone graft but without the provisional. Type D, you put the bone graft with the provisional. And they made a measurement between the buccal and the lingual. And from the gingival margin to the top, and then find out the type A, put the implant placement between the buccal bone and the implant. You don't put the bone graft and you don't put the provisional. The average is minus 0.8 millimeter. You're going to have a collapsion and bone and the soft tissue, which you can see like no bone graft, put the healing abutment, soft tissue always collapse, and also the bone will collapse to the implant. So average is minus 0.8 millimeter you're going to have the shrinkage. How about with the bone graft, with the provisional? You put the bone between the implant and the backbone, pack it tightly, and then you put the provisional on the same day. The average is minus 0.1 millimeter, almost nothing changed before extraction and post extraction and after the surgery. So treatment sequence of immediate implant placement and provisional, you do a traumatic tooth extraction and clean socket, deblide everything, and then partly implant placement, okay? And then place the bone glass between the buccal bone to the implant, pack tightly, and then you always try to make a screw retain provisional, because the cement retain provisional, you can sometimes you can leave the excessive cement, and so you have the gap between the provisional and the abutment. So we prefer to do the screw retain provisional restoration. So that is a treatment sequence of immediate implant placement and provisional. But can you do that always in the aesthetic zone? Which is, first you need to have ideal socket, bone with a soft tissue, okay, which is rarely seen in Japan. And also you have to have great stability, and you don't have infection. Everything has to be in the slam dunk case. How much percentage you can have this kind of slam dunk case in your daily practice. What is the contraindication for these implant cases? So initial implant stability. You need to have at least 30 to 40 Newton centimeter to put initial implant stability to put the provisional on the same day. Okay, so that you need to have undersizing asterotomy, avoid the content sinking, and also sometimes you need to have the like micro design, the tapered versus straight, or the V-shaped, buttress threads design, expanded platform. You always have some ideas and some design of the implant, and for that, getting the initial implant stability. In aesthetic zone, in order to get initial implant stability, you always start the drill in the puzzle. Sometimes you have like a straight shaped drill, okay, and made osteotomy in the puzzle bone. It's really hard, but you made also the first drill to the puzzle bone, and then when you take a tapered design, you made osteotomy like this. They're like a late design, okay? But you always guys to see when you place the implant to the socket, you undersize the osteotomy, your implant is fatter than the osteotomy. So when you're placing the implant, you're going like this direction, but going to the fatter to the apex, though, you don't have any bone on the buccal side. The parietal bone is really hard. So when you screw them in, sometimes implant is going to the buccal side. So this, the red arrow direction. So you try to aim the partly implant placement, but you end up in a straight position. Sometimes you guys still seeing that. So you need to be really careful to do the implant placement for the in aesthetic zone. How about the soft tissue coaptation? You want to keep the soft tissue contour as natural tooth, but you put the implant to the part, and when you put the healing abutment, your soft tissue will collapse to the circular shape because towards the healing abutment. If you have a natural tooth or provisional, soft tissue can keep the same contour as natural tooth, but when you put the healing abutment, soft tissue and the bone will collapse to the circular shape, like this. So after this, when you achieve the nice aesthetic goals, sometimes you make a provisional, you make a custom provisional with a healing, provisional abutment, and you made a contour and made a soft tissue manipulation to get the successful goal. But that is a sequence of the aesthetic zone, treatment planning and aesthetic zone. The problem is that the repeated replacement of the abutment may result in the apical migration of epithelial tissue around the implant and reduction of marginal bone loss, which was done by a study in Abrahamson in 1997, which means that after soft tissue collapse towards the healing abutment, you need to make a wider, like a soft tissue natural contour. In order to do that, you put the acrylic on the top, you made a soft tissue manipulation. You take the provisional, you put the acrylic on that, you put it back again. Sometimes you reduce the acrylic and you put it back again. That is repeated replacement of abutment. That can cause apical migration of the apical tissue, and also you can reduce the marginal bone loss. That is a problem. And then minimizing the number of the abutment and the reconnection would be beneficial to ensure minimum disruption of the peri-implant tissue and the marginal bone loss. That means that if you don't take out and put it together, many times you will save the soft tissue and hard tissue around the implant. And the same group, Abrahamson 2007, healing abutment to the permanent abutment, just one time, you won't change any mucosal attachment and a bone loss. That means one abutment change won't change anything at all. That is a concept of one abutment, one change. So my goal of predictable treatment sequence for the aesthetic zone is avoid the risk of the immediate loading with the provisional and avoid the soft tissue collapsion and keep the soft tissue contour as a natural tooth and one abutment, one change, which means you put the abutment, any kind of abutment, to the final restoration, you can only have one change. That is one abutment, one change. So let's see in the case one. Patient had a bike accident and then he got interruption of the right central. And then the other dentist, past dentist, tried to endodontic and then placed his natural tooth on the top and tried to do the restoration, but the patient gave up and then the pain, and he came to my office. He wants to have an implant. And you can see that at external resorption and also the endodontic failure. So we decided to take out the tooth, place the implant. So carefully, you remove the attachment around the soft tissue, around the tooth, and then always rotation movement to get out the tooth extraction. So you can see the external resorption on the distal. And then check the buccal bone. This is really needs to have, it's a really important process. You check the buccal bone and then check the bone height. And then if you have enough bone, which is class 1 socket type, you can go ahead to do the immediate implant placement. So I carefully place the implant to the buccal, the palatal. You can see the palatal implant placement. And this time I use the straight, the coded healing abutment. And then you can see the gap between the buccal bone to the healing abutment. So I want to keep the same contour like this. And also, I don't want to put the immediate provisional digitization, because sometimes you can see the immediate implant placement don't have any bone support on the buccal side. So I don't want to get in trouble with patient bite something or grinding something. So I don't want to put the provisional, but I want to keep the soft tissue contour like these yellow spaces. How you do that? So Stephen Chu and Salama, Tana's group made a dual zone technique, which means that between the buccal bone to the implant, above the bone to the soft tissue, they put the bias to support the soft tissue. So soft tissue capture the bone particles and also to make bone volume and soft tissue volume to keep the same contour as before. So that's just a dual zone technique. So I put firmly to the implant between the buccal bone and also beyond the bone to the soft tissue area. I put the bone graft in. These times I use a bias material, put the bone tight. And then after this, on the healing abutment, I put a flower composite to make a shell. So this shell keep the soft tissue contour like a small, tiny, thin layer of the paper provisional. And also this can support to bone graft material on the same area, okay? Like this. And the x-ray shows that I have the implant placement and the slate healing abutment. You can see the shell over here, okay? And then I put the bone graft above the implant platform to the soft tissue area, okay? And right on the pictures, you can see the thin layer of the composite shell can support the soft tissue over here on the buccal side. And this unique digitally coded healing abutment, the coded healing abutment is not only the healing abutment, which can act like impression copying. So this healing abutment was made by the two-piece. Normally, you can see the healing abutment is a one piece, just screw tighten and then done. But this healing abutment act like impression coping. So this healing abutment can have the hex position, so anti-rotation. So first, you put the outside housing to the implant. You check the anti-rotation, so it means that the hex was completely captured in there on inside the implant, and then you tighten the screw on the center. And on the top, like this slit and like a dip can have meanings. So when you scan this healing abutment, like intraoral scanner, or take a normal impression, and then you make a scanner to the scan, you will have exactly where the implant is, and also this abutment height, emergence profile, hex position, implant diameter, external or internal. You just need to capture this hex, the dip and the slits. You just need to do that. So this unique digitally coded healing abutment, but act like impression copy, as I said. So when you scan this healing abutment on the top, you will see the slits and like a dot. The computer knows the abutment height, emergence profile, where the hex position, and the implant diameter, and the connection types. So when you scan it, automatically you will know exactly where the three-dimensional implant position. So this time I did a surgery. I put the bone graft material. I put the thin layer of the composite. Day of the surgery, I scanned it with Omnicom. So the right side is post-op pictures, left side is scan. So intraoral scanner is a beautiful thing. You can take impression on the day of the surgery. You don't contaminate any surgical site. And when I try to take impression with like a polyvinyl material, you will contaminate it, or you can rip off this thin layer of the composite. But with the intraoral scanner, you won't touch anything on the surgical site, so you can clean and infect, and then you don't rip up anything from the surgical site. That is the beauty of the intraoral scanner. So I try to mimic the soft tissue contour, and between the buccal bone to the implant, I put the bone graft material, and the blue line means the soft tissue, the thin layer of the composite to support the soft tissue and also to support the bone graft. And then make a final restoration, this contour, and then keep the soft tissue contour is my goal. So abutment was made, and then also the crown was made by the CAD-CAM. So I removed the soft tissue, the composite layer. You will see this small dot of bias material captured by soft tissue. Okay, this is dual zone technique. Okay, so I put the final abutment and the final crown. You will see the contour. Okay, it's a little bit overbuilt. I pack it firmly. Okay, so but you won't see any reduction. Okay, you will see the bone volume on the facial side. Okay, and this was made by all digital, just scanning. Abutment and crown was made by only on the STL file. Okay, I don't have any model. Okay, it's everything in the digital. You don't see any gap between the abutment and the crown at all, and also the bone area. You can see that it's completely above the platform of the implant. So which is goal of dual zone technique. And also if you can achieve one abutment, one change, you don't get any soft tissue reduction and bone reduction at all. Okay, this is 3 years post-op. Okay, day of the delivery and 3 years post-op. And then I want to do the measurement, okay, between the day of the surgery, 3 years post-op, how much change we have. Because Dennis Turner told us, bone graft without the provisional, sometimes you will get minus 5 millimeter reduction on the bone. So I have a scan data with STL5, the day of the surgery and 3 years post-op. I combined STL5 together, okay, and then make a cut on this bucket area, okay? So this blue line and the gray line is a post-op, okay? The blue line is the day of the surgery, and then you will know exactly how much bone you reduce. On the buccal side, I don't put any bone left. So because of the surgery, I get minus 0.86 millimeter, about a millimeter reduction on the buccal, no, the patellar side. On the buccal side, I don't see any bone reduction and soft tissue collapsion. And this means, gray line means that, okay, the gray line in the day of the surgery, blue line is the 3 years post-op. So I get a little bit of the shrink of the soft tissue, but the volume is not a change at all. Okay, so I achieved it, the predictable treatment sequence of the aesthetic zone. Okay, let's go to the case 2. Patient had endodontic failure on the left central. Okay, you can see the pus coming out on the pulpal side, and then she did a multiple root canal treatment, but she ended up with the pain, and then she decided to take out the tooth and then do the next step. Okay, so I carefully take her the left central with always rotational movement. Okay, you can see the flexure line over here, so you don't see periodontal ligament, only this area. Okay, so the flexures was happened. So this is hopeless. I took out the tooth out and then check the bone on the buccal side and then place the implant partly. Okay, between the buccal bone to the implant about the 3 to 4 millimeter, the gap, the same concept. I put the straight healing abutment. Okay, this is also the coded healing abutment. You just need to scan the slit and the slits. Okay, I place the bone graft towards to the soft tissue, always going to the, not only the bone area, towards to the soft tissue up, and then for our composite, make a shell around the surgical site. So the right side is post-op, I know the pre-op, and the left side is post-op. Place the implant with a straight healing abutment. This time I use the 6 millimeter healing abutment. Straight healing abutment. I put the bone graft, okay, and you can see the thin layer of the composite shell. I scanned the day of surgery, okay, and then I send it together, and then you will know. And then when you scan data, you will see this slit and the slots. So in the same size of the healing abutment, we can superimpose it, and then we make a 3 area and combine it together. You will know exactly the 3-dimensional implant position. And then this time, the last patient was a smoker, and also the it doesn't have much aesthetic. In this case, the patient had high demand of the patient, so I want to put more aesthetic outcome for this patient. But not only the milling crown, I want to have zirconium framework with porcelain on the top. But I don't have any model. How are you going to put the porcelain on the STL file? We cannot do that. It's impossible. You can make a clown on this STL file, but you can make a framework, but you cannot put the porcelain on the top because you don't have any adjustment tools, so you don't have any model. So in this time, I decided to make 3D printer model from the STL file, the day of the surgery. I made abutment data on the STL file. I printed it out with a 3D printer. And then this up and lower 3D printed model can easily attach up and lock with the patient bite position. okay, like this. And also the beauty of this model, which abutment can take out with a die model. And then this abutment line, which is exactly the same as the patient natural tooth, okay, like this. So I can remove the abutment and then put it back again, like the same die cast, okay? So I made a framework with a zirconium, okay? Now I have a model, like a normal. So I asked the technician to put the porcelain on the top, the layer of the porcelain, okay? And then make a natural, nice looks contour tooth, okay? You can see the morphology on the facial area and also the gradation on the color, okay? Which is difficult to make only milling clown. So the delivery, I remove the shell. So you can see the bleeding on some bios particles captured in the soft tissue. And then I place it in the final abutment. Okay, this day of the extraction, day of the surgery. Okay, now this time I decided to go to the cement restoration. Okay, because I put the layer of the porcelain. And the layer of the porcelain and the cement type restoration have always had the excessive dental cement problem. 2009, majority of the peri-implant disease cases, 81% of the peri-implantitis can cause by excessive cement. So how you reduce or how you avoid excessive cement? So this die, the 3D printing die, was exactly the same size of the final abutment, because which was made by 3D printed from the STL file. So the first, I put the cement, okay, and then put it back to the 3D cast, 3D die cast. Remove the excessive cement, everything, and then take out from the 3D printed die cast and put the final abutment. Therefore, you don't have much any excessive cement. You have enough, exactly enough cement for value on the final abutment. So you put it back again and then wait to cure so you won't see any excessive cement around the implant. So this is a pre-op. Okay, sorry. This is a depth delivery. This is a pre-op. This is a post-op, the X-ray. You can see the nice contour, almost like natural tooth contour from the implant to the abutment and final crown. You won't see any gap, no bone reduction, okay, and no soft tissue collapsion. Okay, 1.5 year past. Now is the actually 2 years post-op, and the patient is healthy, no problem at all. And why don't we check the measurement? Okay, day of the surgery and 4 month post-op, I have the scanning data. Okay, I tried to make another scan in 3 years post-op to check the measurement. Okay, in this time, is the day of the surgery, and also day of the surgery is a gray. The blue is a 4 month post-op. Even 4 month post-op, okay, always. Schlupp said that after extraction of 3 months, you're gonna have a 50% of the bone loss. But 4 months after the extraction, put the implant placement with immediate bone graft with a soft tissue shell, you don't see any soft tissue collapsion on the bone at all on the 4 month. After this, you put the final abutment, you put the final crown and supported healthy soft tissue on the bone, you won't get any bone lesion at all on the future. So my prediction with digital treatment in aesthetic zone is that immediate implant placement in healthy class 1 type socket, okay, and dual zone bone graft technique between the bone, buccal bone to the implant. You place the bone and also towards the soft tissue, and then make a soft tissue shell, or sometimes you make a custom soft tissue, custom abutment But this time I use the ankle digitally coded implant healing abutment, which you don't need to take out. You put the healing abutment in, you won't take out when you deliver the final clamp, because this healing abutment can act also like implantation coping. When you do the scampers or something, you need to take out this out, okay? But this time, I use digitally coded implantation healing abutment with the digital implantation technique intraoral scanner, and one abutment, one change. You don't take out anything at all in one shot, okay? And then 3D CAD/CAM system, 3D printed technology, you won't get any bone reaction in the soft tissue, avoiding the risk of the placing the provisional on the same day. That is my predictable digital treatment in the aesthetic zone. Okay, thank you for your attention. Thank you for attending the webinar in ICOI. I hope to see you soon. Thank you so much. Bye bye.